Alright guys, welcome back. Today we're going to talk about Streptococcus pyogenes, Group A strep, Rheumatic Fever, and we're going to end with penicillins. I stuck to just one type of penicillins for today because it would get too outrageous, but hopefully everything makes sense. So, moving forward. Alright, Strep Pyogenes. Can you guys tell me? So it's also known as Group A Streptococci. What are some of its general characteristics?
Gram-positive.
Gram-positive.
Okay.
Catalase negative.
Oh, okay. Yes. Catalase negative.
Beta hemolytic.
Beta hemolytic. So what would that be? Bacteriotrace sensitive or resistant?
Sensitive. Sensitive.
The dog.
So this is beta. Yeah, exactly. That's really stupid mind.
Where's the dog?
Fevers.
So Group A are going to be your sensitive ones. So again, like you guys said, it's gram-positive. It's cocci in chains. It's catalase negative. Bacteriotrace sensitive, beta hemolytic, and it's also a PYR positive. This is basically, from what I gathered, was just a detecting agent, and it's the only beta hemolytic strep that is PYR positive. Group B strep is also beta hemolytic, but it's PYR negative, so you can differentiate on a question. And it has M proteins as a variance factor. What is M proteins good for? What do N proteins inhibit?
Like,
So
Coagulation.
Okay, everybody said it at once, so I couldn't hear that.
I said cell wall adhesion.
Okay, any other guesses?
like coagulation. It's like specific. Okay.
Sorry. So it inhibits phagocytosis. It binds to this. In our bodies, there's H class of proteins, and then there's also binds to C3 convertase, which prevents opsonization by C3b. So it basically, this M protein inhibits phagocytosis, and it's kind of a big thing because antibodies to M proteins will then come up later in rheumatic fever, and then M proteins also show up in post-streptococcal glomerulonephritis. So you want to keep those in mind. And most patients who have strep infections won't get both rheumatic fever and post-streptococcal glomerulonephritis. Their M protein subclasses are different, so they'll either get one or the other. So just to keep that in mind. So this is just the chart from first aid. Just wanted to show you that it's gram-positive cocci, it's catalase negative, and then it's beta hemolytic. And so we're going to talk about Group A strep. All right, so what does it cause? Can you guys give me some of the things it causes? I gave you a little hint here.
Cellulitis.
Cellulitis, that's one.
Gas gangrene.
Sorry?
Gas gangrene.
Okay, so you're talking about like necrotizing fasciitis? Or...
Yeah.
Okay.
Isn't it Clostridium perfringens that causes them? Can strep cause?
No. That's why I said, are you kind of trying to say necrotizing fasciitis? But I don't think strep can cause gas gangrene. But you're right, Clostridium will.
Whatever the hell's the one with the honey-crusted lesions, I can't think of that word right now.
Impetigo?
Impetigo, yeah.
All right, so we're talking about pharyngitis, and that's obviously your strep throat. It can cause cellulitis and impetigo. And I'll talk about a little bit about the first two briefly in a second. How about toxigenically, it can cause scarlet fever, necrotizing fasciitis, or toxic shock-like syndrome. Again, we'll get into that in a few minutes. And lastly, it's immunologic or immune disease will be rheumatic fever and pro-streptococcal glomerulonephritis. So let's talk about pharyngitis. Pharyngitis, roughly 15 to 30% of the cases are due to group A strep, but most of the cases are due to viral infections. So why is it important to treat and identify strep infections? Because it prevents the transmission. You want to prevent the transmission, limit the symptoms, and then you also want to prevent rheumatic fever. So how do you diagnose it? You're going to do a throat culture, and then most hospitals and most doctors' office will also have rapid antigen tests, and it's very useful and very effective. But if you miss it on the rapid antigen test, it follows it up with the throat culture. And then treatment for that will obviously be your penicillin or cephalosporins. But most likely you're going to stick with penicillin. And so as far as skin infections, such as cellulitis or impetigo, these can also be caused by Staph aureus, but they can also be caused by strep. So when you treat them with antibiotic, you want to cover both staph and strep. So just keep that in mind, that not only strep, but staph can also cause these two things. And we're going to dive into the rest of these fairly shortly. So any questions about just this slide? All right. So scarlet fever. What do you guys, when you hear scarlet fever, what comes in your mind?
Strawberry tongue.
Sandpaper
Strawberry tongue.
rash.
Okay.
Post-strep Maryland death.
Yeah.
Yeah, that's completely different.
All right. No, you're correct.
Rash on palms and soles.
Okay.
Sandpaper rash.
Correct. So it's the rash that follows pharyngitis, skin reaction to erythrogenic toxin. So it basically is a toxin that is transported via lysogenic phage. So it's not something that the bacteria has, it just gets. So typical signs and symptoms, you're going to see fever, sore throat, diffuse rash, red rash, and as you guys said, sandpaper rash. Starts at the head or neck and expands to cover the trunk. Strawberry tongue is a classic finding. And where else do you see strawberry tongue? What other disease?
Kawasaki.
Kawasaki. But Kawasaki also has strawberry tongue and a rash. So how do you differentiate Kawasaki with scarlet fever?
Conjunctivitis.
Okay, that's one way, but the other quicker way is sore throat. So Kawasaki will not have a sore throat. But that's typically for your board exams. In a clinical setting, it's probably really hard to differentiate. These rash for scarlet fever does not affect the palms and soles, but there are three. I know that we've covered some diseases that involve rashes on the palms and soles. Could you guys tell me those three?
Syphilis.
Syphilis is one.
Rickettsia.
Yeah, Rocky Mountain spotted fever. And Coxsackie virus, right? That's the other one. All right. So this is your strawberry tongue. Kind of looks like a strawberry. And this is probably not the best picture for a sandpaper rash, but it's the one I found on Wiki. But it kind of gives you a good idea as to what it looks like. So this is basically just a review slide. I'm not really trying to highlight much from here, except we've covered most of it. Strains that cause impetigo can induce glomerulonephritis. I think, Pete, this is what you were trying to say a bit earlier. And pharyngitis can result in rheumatic fever and glomerulonephritis. So, again, keep that in mind. And the M protein, again, like I said, you can get M proteins for both rheumatic fever and glomerulonephritis, but they're just different subclasses. So those diseases can happen, but they won't happen together, or they won't happen. Both those diseases will not happen in the same person. they'll get one or the other. This ASO titer will come into play a little bit later. And again, phagocytosis by the capsule and the M protein. So kind of covered everything else on this slide. So any questions about this? All right, so let's forward. So, as you can see here, super antigens cause the shock, right? So Staph aureus can cause the toxic shock syndrome, and that's because it's a super antigen. And I'll explain, or I'll try to explain, what this whole thing means in a diagram shortly. But Strep Pyogenes also has an exotoxin A, which can cause toxic shock-like syndrome, which involves fever, rash, shock, and scarlet fever. So typically in a normal antigen, how is a normal antigen presented? Well, the antigen presenting cell takes it and then it puts it on the MHC class. It presents it to the T cell. So normally you're going to activate one T cell, right? But in this case, on a super antigen, what it's doing is it's kind of, like it says, the APC outside of its antigen binding site, so it's not actually in the MHC. It's just presenting to it on the side, and it's activating a ton of T cells. So this could activate up to, let's say 20 T cells simultaneously. So it's not, an APC is not taking it and presenting it as it normally should. It's just cross-linked. It's cross-linked the beta regions of the TCR and MHC essentially on the side, and it's just activating a bunch of T cells, which will then cause release of IL-2, INF gamma, TNF alpha, and that will cause you the shock. So hopefully that makes sense as far as how the normal one versus a super antigen differentiates, and why.
Essentially like forcing it to react, right?
Correct, yeah. So it's just making it go crazy instead of just, having a systematic way. So if you like diagrams, this is essentially what this is trying to say. So any questions about that?
No.
Cool. So we'll move to our concept, which is going to be rheumatic fever. So acute rheumatic fever is essentially pharyngitis that occurred in a young child 2 to 3, and then post 2 to 3 weeks of that pharyngitis, it causes rheumatic fever. Essentially, it's caused by molecular mimicry, so M proteins that resemble proteins in the normal tissue. So it's basically cross-reacting with tissue antigens, and that's a type 2 hypersensitivity reaction, which is an immune-mediated reaction. And we're going to talk about the diagnosis in a second. And acute attacks usually resolve but can progress to chronic rheumatic heart disease. And that's typically due to repeat exposure, can result in a relapse of the acute phase, and then increase your risk of chronic disease. So once they go away, you can get re-exposed, and that can increase your risk for chronic disease. And we'll talk about chronic heart disease towards the end. So let's talk more about the Jones criteria, and as well, you're going to see an elevated ASO titers. I just don't have it anywhere else besides the first aid review page, so just keep that in mind. So Strep Pyogenes releases a streptolysin O toxin. Basically, this is protein that degrades the cell membrane. These lyse the RBC. So how is strep beta hemolytic? There's such a thing as streptolysin O and then an S. The two streptolysins help strep become beta hemolytic, and these basically are host antibody against the toxin, and these are used to diagnose rheumatic fever. So that's the other toxin that this guy can release, and you can find ASO titers effectively to diagnose rheumatic fever. But essentially, streptolysin O and S make this beta hemolytic. So that's essentially what I wanted to talk about here. All right, so Jones criteria. So there's major criteria and then there are minor criteria. The minor criteria are non-specific. They're not really going to prove anything. But you can see an elevated ESR, prolonged PR interval. You can have a prior rheumatic fever, or any of these things are just minor criteria that you might see. For a major criteria, there are these things, and we'll go through them in detail. But you also need to have evidence of strep infection. So either you're going to look for elevated ASO or anti-DNA ACE-B titers in a patient. That will give you the evidence of a strep infection. So the major criteria, let's start with migratory polyarthritis. So this is basically swelling and pain that are going to be from large joints, such as your wrists, ankles, or knees, and they resolve within days, but then they migrate and involve another large joint. So you're going to see that in a Jones criteria. So polyarthritis, it's migrating, going from one spot to the other side. Now, pancarditis or carditis, there's three things that can affect. You can have endocarditis, myocarditis, and pericarditis. And let me go to the next slide, and we're going to talk about all these in this slide. So here's normally what you would see normal function here. These are just blown up in a way that shows the differentiation of endocarditis, myocarditis, and pericarditis. And I got it from this website, so if anybody wants to go, check it out. There's ways you can click on it, and it'll show you what the differentiation between a normal and pathologic animations are. And then they also have histology slides, which you can see. So in endocarditis, you're basically going to have mitral valve, which is going to be the most commonly affected, more so than the aortic valve, as we know in rheumatic fever. And it's characterized by small vegetations that basically line of the closure that leads to a regurgitation. So in endocarditis, in an acute phase, you're probably going to see mitral regurg, and that's due to these small vegetations. Now, in myocarditis, you're going to basically see two types of cells. You're going to see Aschoff bodies, and I have a slide. The next slide, I'll show you a picture of Aschoff bodies and what they are. And I'm going to try pronouncing this word, and I know I'm probably not going to get it right, but Anschau cells, is that correct?
Anetscow.
Anetscow.
Something like that.
Yeah, and
Some
again,
dude should want his name is medicine.
yeah, it's complicated. And I kind of wrote it down and broke it down, but I knew I was still going to screw it up. But I'll show those as well and what they mean. And myocarditis is the most common cause of death in an acute phase. So if you have acute rheumatic fever, myocarditis is the most common cause of death. And again, I'll talk about those two cells very shortly. And in pericarditis, obviously, it's going to lead to friction rub and chest pain. So that's going to involve the pericardium. So the Aschoff bodies are just basic cardiac nodules with inflammatory cells, so granulomas, essentially. And on this histology slide, it's right here. Well, that's a bad color on a pink. Sorry. Try this. It's right here. This is an Aschoff body. And then this Anti-Schau or Anti-Schau cells, it's basically a macrophages with an owl's eye appearance. So again, it's going to be right there. Yeah, so these were what you would see in a histologic findings in basically a myocarditis phase. So this is what would affect the myocardium.
Is one? Did you say that one is specific to endocardium and one is specific to myocardium, or are they both myocardium?
No, these are going to be both in myocardium. So myocarditis with these Aschoff bodies are basically foci of chronic inflammation and relative histiocytes with a wavy nuclei. So basically, it's this, but inside is this. That's my understanding of it.
I see. Okay,
So
that makes sense.
yeah, there's a bunch of these guys I think in here that makes this Aschoff body.
Bunch of the macrophages together make that. Okay, that makes sense if it's granuloma. Macrophages make up granulomas.
Yep. So any questions about this?
Oh, that makes sense.
Go back here. You also have your subcutaneous nodules. Erythema migratum is just a non-pleuritic rash with erythematous borders, and that usually just involves your trunks and limbs. And then chorea is just rapid involuntary muscle movements. So that's going to be your Jones criteria. That's going to what you need to look for. So either you need 2 major or 1 major and 2 minor to basically say you have rheumatic fever. Any questions? All right, so I kind of covered basically everything, but just wanted to add this that heart valves that are typically affected are going to be mitral greater than aortic or tricuspid. So just know that if you see anything with rheumatic fever, mitral might be more common than aortic, but that doesn't mean aortic isn't affected, which I'll talk about. But it's just very less often involved. And early lesions lead in mitral valve regurg, as we talked about earlier, but late lesions is mitral stenosis. And basically, this is another picture of Aschoff bodies. And like I said, it's an immune-mediated type 2 hypersensitivity reaction, and antibodies to M proteins cross-react with self-antigen. That's what I was trying to say, which is a molecular mimicry. So that's how these things basically work as a type 2 hypersensitivity reaction. Treatment, penicillin, and then if you need a good mnemonic, here's a Jones criteria mnemonic that you could use. And then the carditis, you can have the 3 different types of carditis. All right, so what if you have chronic rheumatic heart disease? So the valves will start scarring and rise to consequences of rheumatic fever, and so it results in stenosis. Almost always involves the mitral valve, but which leads to thickening of the chordae tendineae and the cusps. I have a picture of that I can show you. And occasionally it involves the aortic valves, which leads to fusion of the commissures. Again, I'll show you. And if you read Pathoma, he says that results in stenosis with a fish mouth appearance. The only thing that I could think of fish mouth was when I saw the picture of the aortic valve. And I'll show
the fusing of the commissures as you have there, the fish mouth.
All right. So the other valves are very less commonly involved. So, and complications would lead to infectious endocarditis. So here's a picture of a thickened mitral valve, as highlighted by this little diagram. And the fibrotic fused chordinae would be these guys right here. These guys would be the fused chordinae, tendineae, basically. Again, I got it from the same website. And the fused commissures would be right here, and they kind of look like a fish mouth, if you break it down. And you have a narrowed orifice in the center. And that's usually aortic stenosis, what you would see in aortic stenosis. Well, this one is basically mitral stenosis. All right, so any questions before we move on to our drugs for the night?
Nope.
All right, so penicillins. So we're just going to talk about Pen G and Pen B. Pen G is your IV or IM form, and Pen V is your oral type. So they both have structures that are D-ALA structure analogs, and they bind to penicillin binding proteins, which are transpeptidase. So what is the mechanism of penicillins?
Breaks down so long.
Yeah, so it blocks the transpeptidase cross-linking of the peptidoglycan in the cell wall. So it basically activates autolytic enzymes. And if I'm correct, if what it means by autolysis or autolytic would be the cell breakdown is greater than the cell creation. Like you're not creating new cell wall, but you're breaking it down a lot more. So that's my assumption of autolytic enzymes or enzymes that will help break down cell wall. I don't know if anybody has any other things to cover that, but that was my understanding of it, where your cell wall breakage is greater.
I think it might have to do with the fact. Okay, that makes sense what you're saying, because the mechanism is blocking cross-linking. So it's essentially blocking the building of the structure of a cell wall. So probably the ratio of autogenic and autolytic enzymes, you're probably autolytic is going to overpower because you're preventing genesis from occurring. So maybe that's what that means.
Yeah. So, I mean, my assumption was that, yeah, since you are blocking the cross-linking, you're not producing new cell wall. Mm-hmm. So you're also breaking it down, though. So that's why I assumed that that's what autolysis meant. So.
Yeah.
Just eating itself. It has enzymes that are destroying itself. That's what it's turning on.
Okay, that makes sense. All right, so what are the clinical uses of this? So most likely for what? Clearly it's not gram-negatives because that's here. So that only leaves you to one possibility.
Strep.
Yeah, basically. It's gram-positive organisms, so Strep pneumo, Strep Pyogenes, or Actinomyces. But it's used for most of the gram-positive organisms, specifically these guys. It's also used for a gram-negative cocci. Do you guys know which one?
Borrelia burgdorferi?
No. It's Neisseria meningitidis. As the gram-negative, mainly for that one. So it's also bactericidal for gram-positive cocci, gram-positive rods, gram-negative cocci, and spirochetes. So basically everything it covers. And it's a beta-lactamase sensitive. So ADRs for this one.
Rash.
Okay, rash.
Allergies.
Correct.
C. diff.
C. diff. Yes. So it leads to multiple types of hypersensitivity reactions. As Pete said, rash, which would be a type 1, which is IgE mediated. Within 1 hour, causes your bronchospasm, anaphylaxis shock, essentially, due to your histamine release. It can cause hemolytic anemia, which is due to penicillins binding to your surface RBCs, which elicit an immune response, and antibodies against the penicillin-bound RBCs are created, and that will cause a direct Coombs test positive and cause a type 2 hypersensitivity reaction. As far as for that one, and interstitial nephritis, basically the drug would act as a hapten and elicit an immune response in the kidney, which is a type 4 hypersensitivity reaction, and that will present with fever, oliguria, increased BUN and creatinine, eosinophils in the urine, white cells, and white blood cell casts on basic findings. So those are the things here.
Drug-induced interstitial nephritis is a type 4? Because
I have. I mean,
because it's delayed?
Yeah, I think so. I mean, I'll double check it, but that's what I have.
No, that's cool.
And basically, I wanted to cover, when you talk about, when first aid says this hypersensitivity reactions, I always get confused. Are they talking about type 1, type 2, type 3, type 4? So in essence, penicillins can cause a variety of hypersensitivity reactions. So type 1, again, is your anaphylaxis. Type 2 would be your hemolysis due to IgG. Type 3 is serum sickness, which typically does not affect just these penicillins, but other penicillins. and that's also via IgG. And then nephritis is type 4, and your skin infection or skin reactions that can happen with penicillins, other types, would be essentially type 4 as well, and that's because of your T cells. So that's a quick kind of review. I didn't go into detail with all these. It could be another whole lecture, but I wanted to say that penicillins can cause a variety of type hypersensitivity reactions. So, because I always thought it's type 1. It has to be a rash, but it could also do hemolysis, which is type 2, and nephritis, type 4. So that is it. Any questions?
Oh, that was good. That was good.